Hello, and welcome to the Health Go Live webinar series. Today's episode is brought to you by our friends at Bind. We would like to remind you that the Q&A feature will be available, so feel free to send in those questions for the panelists throughout the discussion. And with that, I will turn it over to our moderator, who joins us from Med City News, Arundhati Parmar.
Thank you very much, Nicole, for that introduction. Hi, as was mentioned, I am the editor-in-chief of Med City News. And so as the song said, better days are ahead. We've been in a tunnel tunnel toward end goal being full consumer empowerment. And we've had glimmers of hope here and there where consumerization trend, for example, in having same-day appointments or being able to do a telemedicine visit. We've had some of those along the way over the last few years, and some of those trends have only accelerated during the pandemic. But today there is a big part of consumer empowerment that we're going to talk about, which is price transparency. And we have a wonderful panel who I'm going to introduce in just a second. I know it was mentioned that you could send questions in the chat. That's wonderful. Please go ahead and do put questions for the audience. But I would urge you, excuse me, to wait until each speaker has had a chance to speak so you can hear each of their perspectives before deciding on a question. So first, we have Trevor Fast, Chief Actuary with Bind Benefits. Then we have Nick Wheely, Partner at Foley and Lardner LLP. And last but not least, we have Christina Brenner, SVP of Total Rewards at MasterCard. Welcome to all of you. So Nick, I'm going to start actually with you. I understand that certain rules have been in place in the last year. Some new ones went into effect January 1st, and there are more coming in January 1st, 2023 and 2024. So if you could sort of describe the lay of the land to us, what is in effect right now and what is coming in the future? I think that'll help everyone.
Yeah, absolutely. Happy to. In my opinion, it's sort of a new wave of healthcare reform. If you look at like the text of the ACA and you just look at like the health benefits provisions, and you look at the text of the new stuff that's come out from the CAA, the Consolidated Appropriations Act of 2021, and the ACA regulations that recently came out on this topic, it's actually longer than the ACA. So I do think we have a whole new tidal wave of responsibilities and compliance requirements that are going to require things like price transparency and data disclosures. And so the two biggies that we probably care about today are there are certain ACA Affordable Care Act regulations that came out fairly recently that are going to essentially require data to be disclosed on websites about provider reimbursements in network and out of network and service codes and what a provider gets paid for those service codes. And then there's a whole slew of new requirements under the CAA, which I just mentioned, that also kind of touch upon price transparency, whether it's prescription drug reporting, aggregate health plan spending, air ambulance claims, and even things like a self-service compliance tool where someone can look up at the compliance tool and see before they see a doctor, what will my costs be? What's my co-insurance? Where am I at with my deductible? If I see this doctor, is this doctor in network? So there's actually several different requirements that we're talking about when we mention price transparency generically. And to make things a little more confusing, of course, there are kind of staggered effective dates. Some of these requirements are already in place. One of the big ones that I mentioned, the ACA, sort of on a website, public information, anyone can consume it. That's going to happen for most health plans this July. And then we have other requirements that are going to be in effect at the end of this year, and then at the beginning of next year, and even into 2023 in March and into 2024. So there's lots of different requirements, lots of effective dates, but I think over the next few years, we're going to see the dust settle and we're going to see how this is all going to play out.
Okay, sounds good. Before I go to Christina and Trevor, certain rules went into place last year, and only if I think it was related to hospitals providing their charge sheets, and very few organizations are actually complying. And given the situation we're in right now, I don't think it's palatable to be enforcing, that regulation on hospitals that are already dealing with so many issues, including the pandemic. So what kind of enforcement do you foresee for employers that are not complying?
Yeah, I do think it's going to be a different animal. I know for the healthcare providers, there was definitely less than 100% compliance. I'm not a healthcare provider expert by any means, but I know one of the factors was the penalties was fairly low when it originally came out. They're changing that. But on the health plan side of things, I believe the consequences could be a little more dire. I think there's different regulators and different market levers. Just as an example, for like a fully insured health plan, I know a lot of state insurance departments will ask the carrier, hey, in your certification, your insurance application, please certify that you're going to comply with these rules in order to sell a fully insured product to the entire state. So, really huge consequences if that carrier doesn't do it. And I've seen that in my professional practice. And then on the self-funded plan side of things, the plan sponsors technically have that legal responsibility to do the reporting, technically speaking, it's the employers that have to do it, right? Sure. But we all know it's their plan service providers, their TPAs, their PBMs that are actually going to do it. They have the resources, they have the data, they have the systems in place. So plan sponsors are going to go to their TPAs and PBMs and say, hey, can you do this on our behalf? And if they don't, then the plan sponsor, being an educated consumer, is going to shop elsewhere. So I think there's a real market incentive for TPAs to also do it. And on top of that, there's also potential DOL enforcement and some pretty stiff IRS penalties that could apply. So I do think we're in a different regulatory regime than what we're talking about for the healthcare providers. And I think there's different sort of motivating factors there to get it done. So I think we're going to probably see some more compliance than we did when the rules first came out for the healthcare providers. I don't think TPAs and PBMs are going to put on their front webpage like, hey, we just made all these disclosures about in-network rates. You should go check it out. It's really easy to get to. But I do think we're going to see a consensus on trying a good faith effort to comply with these rules.
Okay, Christina. So Nick provided the context for which you have to operate in. It's a daunting task. How are you looking at complying with these regulations?
We're going to be heavily relying on our partners because we don't have the expertise or capacity to do it in-house. So our TPAs, our care navigators, our second opinion services. So anywhere that we can rely on the partners that we have in place. And that will involve us leaning on them to make sure that we are compliant. It is important for us to be compliant. And we see part of our partnership is the other side helping us to stay compliant. So it'll be something that we navigate with our partners.
And when you say partners, can you name some people that or some companies that you're working with that can help in this process?
Yeah, so obviously our medical provider, which is UHC, we are onboarding with Accolade, which we hope to help with the overall employee experience, which is very important to us at MasterCard. And then we use a opinion service through Consumer Medical that we also look to lean on.
And then, Christina, just so the audience gets a sense of how large you are, I think most of us have a sense, but how many covered lives within your organization?
We're about 11,000, and our employee footprint in the US is actually a little bit smaller than our total employee footprint. So total lives is about 11,000.
Okay, so Trevor, I know a little bit about buying benefits. I know that, making consumers understand insurance very easily is a big focus of what you do. But we're going to put that aside for just a second. I want to ask you from this TPA perspective. I know you don't work with MasterCard, but for the self-insured customers that you do work for, how are you helping them, given that they have the liability, but they're depending on you to help them not get slapped on the wrist by the regulators?
Yeah, absolutely. So, Bind is a subsidiary of United Healthcare, and because we use United Healthcare's broad national network, we're closely partnered with them. Actually, similarly, probably to what Christina described. We're partnering with United Healthcare just as they're fulfilling those requirements for their other customers to deliver those same capabilities to Bind customers. It is really important. Compliance is top of mind for the 100 or so large groups that have selected Bind to be their TPA or fully insured provider of medical benefits. And so we're partnered with United to use their network capabilities to deliver that same level of price transparency for compliance purposes. However, of course, we at Bind think that the letter of the regulation in terms of compliance with price transparency doesn't really meet the full need from the consumer perspective.
And I was going to just segue into that. So thank you for mentioning that. Consumer empowerment is a large challenge, right? And just having a website where you have this information overload and feel like, whoa, I've disclosed everything that there is to know. Now it's the consumer's job to figure it out. Does that go far enough?
Yeah, I don't think it does. While appreciating the spirit of the regulation, and I think it's going to help move the industry in a productive direction, I don't think it's sufficient for really empowering the consumer and unlocking the power of what that could bring to bear for the market. Mm-hmm. There are a couple of reasons for that. When you look at there's a scheduled list of target services, shoppable services that have been defined under the regulation, and it's defined in terms of course, the CPT code book. And so when you delve into the regulations and you think about, practically speaking, if I give all of my plan members or my clients' members rates for all the J1745 codes in the market, how effective is that going to be at helping them shop across cost and quality? First of all, of course, quality is nowhere represented in that price transparency, but there's also an issue that as providers bill for these services, they're never or very uncommonly are they billing for just a single code. They're billing for a bundle of codes, and how they code and bill for even a similar care encounter differs tremendously from one provider to the next. So I think what's really important for the consumer is enabling better tools and packaging into an intuitive, meaningful care unit. What I would refer to as cost clarity or cost certainty of the entire encounter that they're pursuing, rather than just at a CPT code level.
Makes sense. Nick, before I ask you the next question, an attendee wanted you to speak a little bit more about the CAA and what is the expansion of the acronym and what does that actually refer to?
Yeah, so in late 2021, we had a huge bill be released called the Consolidated Appropriations Act of 2021. There was a lot of things in there, a lot of it COVID related, but there was also a huge amount of text relating to health plan requirements, compliance requirements for health benefits and the like. And so, here at Foley, we put together a list of sort of all the various legal requirements that were imposed by the CAA on health plans. And it's a 3-page document with several different requirements that are coming out. Again, all with kind of staggering effective dates. But I think the overall spirit of it is educating the consumer, sharing price transparency, fee disclosures, making sure we're understanding the fees that all the plan service providers are receiving, and also trying to stop balance bills and surprises to our health consumerism. So I think that's sort of the overall spirit of the CAA. Again, it stands for the Consolidated Appropriations Act. There was a lot of text in there, a lot of different legal requirements. Some of them have been deferred by the regulators. Others have not. Others have been, given sort of a good faith temporary enforcement. But we have various legal requirements, all kind of capturing this spirit of let's make health plans better and more transparent. Let's make sure the consumer is more educated, and we stop things like surprise billing. That we stop having people go to a provider not knowing if they're in network or out of network, and not knowing what their true cost of the care is going to be.
So the No Surprises Act is just a part of the CAA, if I'm reading you correctly.
Correct.
Okay,
Yep.
Perfect. Trevor, there was one point, I'm going to come back to you in a second, but just FYI, some people are having problems hearing you. So maybe if you can speak up, I can hear you perfectly, but next time you answer, if you can speak up. Christina, information is powerful, right? But information can also lead to some uncomfortable situation. And I imagine that once you begin getting all the information, you will find that within the same region, there are grossly varying prices for the exact same procedure coming from different providers. How will you handle that?
Yeah, so I actually think that problem exists today. And if you use the tools that we already have, you can find out those variances. And that's one of the reasons that we're partnered with Consumer Medical to kind of help employees navigate that, especially when it's a bigger event like a surgery or something like that. So I personally don't think it's going to change anything drastically. I'm actually a little bit more worried that it will cause more confusion for employees. So we really are going to heavily drive them to the things that we have in place that we're putting in place, because those are meant to help them make better decisions from a financial standpoint, from a quality of care standpoint, and then provide them with a better experience. So we are going to drive people to the things that are going to be useful, that kind of already exist for them. So we really don't think it's going to be a big shift, at least for our employee population, and we'll continue to lean on our partners.
So you're saying you don't expect immediately for it to be a big shift for employees?
No.
Okay. Trevor, I'm going to actually ask you that similar question, because I feel, and maybe stupidly so, that people will want to drive costs down if they see that there's a huge variation. Employers will want to do that. But at the same time, cheap doesn't always necessarily mean great outcomes, right? In the healthcare world. So how do you balance all that? How does the consumer, the average employee, part of this network, understand where should I go? Because I might find a cheaper hip replacement option, but maybe that provider has a higher revision surgery rate. So these are difficult questions to navigate. Who helps them out?
Yeah, it's a great question, and I think gets at the heart of why the transparency rules in the NSA, adopted as part of the CAA, are really insufficient to the full objective here. It takes a broader vision around packaging quality and outcomes and provider practice patterns, along with transparency of cost, to really help people find the best high value outcomes. So I would think about it as value-based transparency, not just price transparency. Mm-hmm. So the way we approach that is I think benefit design is really important in this equation as well, because if you have a plan design that forces people to do a lot of algebra against those prices, we're putting that much more of a hurdle in front of them actually making good use of that information. So, and what I mean by doing algebra with it is, if you have high deductibles and co-insurance in place, you're asking people to do algebra against those price schedules to try to figure out what their costs are actually going to be. So I think one of the things that's important is to consider the impact of quality in concert with cost transparency, to get at value-based transparency, and then to wrap that in more intelligent benefit design that helps people make better use of that information and continues to direct them to high-value care. That also means, in my opinion, that the value that you get from someone on your plan making a high value decision in January should be the same as it is in December. And so again, if you have high deductibles in place that take someone with a chronic condition and have them paying much more for their high value care in January than in December, that's that's not going to achieve the same objective in terms of getting people to stable, consistent, high-value care over time to manage their condition.
Thank you for that. Christina, this next question is for you, although I think Trevor might have an opinion on this too, and Nick as well. So the question is, why will transparency work now? Most people do not think about prices until after the procedure. Castlight Health is a great example of a technology offering that landed flat in the employee benefit market. I mean, I know a little about Castlight. I feel like they were probably a little bit ahead of their time, and also there were execution issues there. But the question is very valid. Why will it work now? Christina?
Yeah, so I think it's about how it is implemented. So if we just list a bunch of codes and employees can't understand, and their partners can't understand, and their dependents can't understand, it is going to fall flat. So I think it's important to make sure that we have the right experience and tools in place so that employees know where to go when it matters. A surgery doesn't happen every day, so it's something that you think about before you plan on who and what you're going to go to. So I think it's about having the right experience and tools in places so people don't feel overwhelmed as they're referring to the data, and that they know that when something big comes up that they're about to experience, that they have steps to take in order to kind of go to the right place. So again, the reason I don't think it's going to be a big shift to put them in place, because our goal has always been quality care at an affordable price. And if employees are left to their own devices with no help whatsoever, then I think it's going to be very hard for them to decipher what they're doing. So I think having the right tools, and to Trevor's point, the benefit design in place to kind of help navigate them, I think is almost more important than the transparency rules.
So Trevor, any comment from you? Why Castlight Health failed and why you guys are going to succeed now?
Well, I'm not going to cast aspersions specifically on Castlight, but I would say one of the challenges with maybe what I would characterize as the first generation or the early attempts at transparency is that if you take a third-party tool and attempt to overlay it on a network way that's not heavily integrated with the actual design, benefit design, and adjudication of that plan, you're going to have a mismatch in expectations for the consumer. You're inevitably going to be showing someone a range of price at a location. In some cases, it might be a wide range of expected price at a location, and you won't be able to guarantee it. You won't be able to live up to that promise. And so sometimes people are going to have costs that fall higher or lower than that range, again, based on the variability of how the provider codes and bills for those services, and due to variability in their contracted rates. So there has to be that really tight, I think this is where the having it incorporated into a sort of a full stack, I'll say, that allows us to guarantee that cost certainty, coupling the consumer tools with the plan design and with the network, having that all in one place is the way that actually allows us to go beyond just transparency and actually guarantee that the price a consumer sees, the price we tell them they're going to pay for whether an office visit or a complex surgery, is the exact price that they're going to have to be responsible for at the end of the day. And so that's why we've designed our plans with no fuzzy math, no deductibles, no co-insurance, only what I would call value-based copays that vary based on the service and the quality and efficiency of the provider delivering that service.
Nick, question for you. With employers shifting the cost to the employees, it is imperative to provide as much transparency as possible, including price and quality. Large employers and employer associations need to demand that providers and payers offer this when doing their annual benefit negotiations. What are your thoughts on this?
That's quite the question. No, and I think you're absolutely right. I think 20 years ago, or maybe even 30 years ago, it was buy a fully insured plan, very paternalistic, low deductibles, very little cost share liability. And now fast forward to today, you got HSAs and you got high deductible health plans, and you got supplemental benefits, you got care navigation and second opinion, and consumer tools. And it's just a whole new world of being a health plan member and experiencing care and trying to get coverage for it. And I think, as you mentioned in your previous question, there are a lot more responsibilities on health plan members to consume correctly, to educate themselves first, and to know exactly what they're getting into before they utilize a healthcare provider's services, right? Because there could be a large deductible attached to it, or an out-of-pocket maximum or cost share. So, certainly we've seen as a whole, the employers have been shifting to high deductible health plans. They have been shifting to make sure that the employees have skin in the game, which is sort of kind of the whole point of HSAs when they came out, right? Is that you'll be a smart consumer, because but for some limited exceptions like preventative care, consumer, you got to pay the full freight until you hit that deductible, right? And so I think there really has been a shift to make sure the health plan members are smart consumers. I think we're still going that direction, which is why we want more data, which is why we want more price transparency. But the employers are definitely shifting costs to employees, and I think that's done at a whole scale level. I don't think it's any one particular employer. And so I do think it's employees should feel somewhat entitled to have things like the self-service tool, to know what the PAR providers are going to get reimbursed, to know what the out-of-network providers are going to get reimbursed, and to know that they're not going to be caught with a surprise bill, or they want to know what the most expensive drug was on their plan and how come it's costing their plan as a whole to increase 3% in the premiums. All that stuff, I think they're entitled to that stuff because they are paying more for this, and it's no longer that paternal health coverage that we used to have back in the day. And so, I think though, like MasterCard's a great example, and other large firms, some folks and some employers are already doing this, right? They're already making sure that their plan members have self-service tools that is now going to be a requirement come 2023. They're already making sure they understand when they're out of network and when they're in network, which is another requirement that's going to come into effect. So I agree with you that employees should definitely feel like they deserve the right to know this information, because premium prices are increasing, their share of the premium is increasing, cost share is increasing for them. And so I do think these rules will help align with that concept and help employers obviously give the employees the information they want.
Christina, I wanted to ask you about this whole, health and benefits space. We've written about it at MedCity News that employers spend a lot of money on care navigation, on benefit design, on all these consultants who say we will make your employees' life absolutely easy when they're trying to look for healthcare services. But I don't know that the return on investment has been there from these sorts of companies. And yet employers keep spending on these. The usage or engagement numbers aren't great from an employee use perspective. So I'm wondering how you take a look at, like when you went to decide that you wanted to select Accolade, because it is one of those companies in that space. What made you decide that, look, this is the best company, even though the overall space has yet to prove itself?
So we look at things for two different ways. The first is experience. So what Accolade is going to give our employees is an easier experience, because healthcare is not easy to navigate, especially as just an individual who maybe has access to the UHC website but doesn't know much more. So the first and foremost is it's going to give our employees a better experience. We do have a lot of different benefits, so it's going to produce more engagement in our other benefits, we believe. And then the third is that there has been a cost savings that has been presented to us. We haven't implemented yet, so I can't really talk about if that's going to come to fruition or not. But we aren't moving away from high deductible health plans, so that's here to stay. So how do we make sure that our costs are being contained in that network that we have while the employees are getting a good experience and quality outcomes? So with some of the things that we've had in place, so consumer medical as an example, we have seen outcomes that are very positive. We have really great employee feedback, which is very important to us. And then also we've seen cost containment through that service itself. So I think for us, cost is an end all be all. It's important. And if we don't put these things in place, would we have such a bad employee experience that we have to revert back to a PPO or something like that? I don't know, but we need to we've committed to the high deductible health plans. We've got 3, and one is very, very high. that I happen to be in myself. So I think anything we can do to help our employees navigate that will, in the end of the day, keep our costs contained as much as we possibly can.
Trevor, another question from you from the audience. Do you think the TransCaring model is the future of medical benefits for self-insured employers? I'm giving you all the competitive questions.
Well, I'm not sure I'm best positioned to comment on TransCaring's model specifically, or that I know it well enough to comment on it. But maybe I can pick another audience question.
Absolutely.
To clarify. There was a question that came in about elaborating on what's meant by this no deductible, no co-insurance type of product, and so maybe just a couple of words on that. So the way this works is that rather than having any elements of what I would call fuzzy math, that's a technical actuarial term. Rather than having any fuzzy math in the benefit, such as deductible and co-insurance, that leads the member, even if they have price transparency from providers, it still leads the member to uncertainty of what they're going to pay at the end of the day. In these plans, there are only what I would characterize as value-based copays, meaning there's a fixed price that's knowable in advance, that's set based on the expected practice patterns of doctors and hospitals, how they perform in terms of quality, outcomes, efficiency, and yes, their contracted rates with the network. And we can nudge members to make better decisions, not by limiting the network, but by giving them lower price tags or value-based copays when they make high-quality, efficient care decisions across their care journeys. And that works whether we're talking about something like an office visit or something like a knee replacement or hip replacement. One of the contrasts that I would draw to something that an aspect of high deductible health plans that I don't think works as well as it should, or arguably even as intended when high deductible health plans were first rolled out, is that for really expensive surgeries, take a hip replacement or a heart surgery that costs 5 or 6 figures. So generally, even with price transparency, members are going to simply reach their out-of-pocket maximum no matter where they go for that service. So they actually don't have, for some of the most expensive services where prices vary the most in the market and where quality and outcomes vary significantly in any local or regional geography, most members on high deductible health plans don't have aligned incentives to find high quality, efficient providers, because they're simply going to pay their out-of-pocket maximum regardless. Not only that, but let's say they have that surgery in January, the rest of the year all their care is free. So they have no more incentive in that quote unquote consumer driven plan to shop wisely and use care effectively. So I think when I talk about better benefit design, one of the principles behind that is thinking about how we can continue to help consumers make better care decisions at every stage along their care journey, no matter where they are in their plan year. And that means really minimizing their costs when they make high quality, efficient care decisions, because that allows us more I'll say bites at the behavior change apple through the year, rather than having someone max out their out-of-pocket limit too quickly.
Trevor, clarify some point for me. I do appreciate the model that you have, where it's sort of when you need a procedure, you can plan for it effectively. That seems to be, that seems to be great for the normal is not the right word, but someone who is fairly healthy, some issue comes up, and they know ahead of time that they will need maybe a hip replacement, and then they can opt in and buy that option from Bind. And so they'll see their premiums maybe go up just a little bit for that period as they avail of the service, and then it'll go right back down again, if I understand your model correctly, after that service has been consumed. But what about unplanned for emergencies? How does your model take that into account? Because healthcare for many people is not predictable.
Yeah, it's an interesting question. I think there's been a lot of debate recently about how much of healthcare really is shoppable and plannable versus the what you're describing. So in this model, we, rather than setting value-based copays on something like an emergency room service, those are set at fixed copays, but also following the principle that no one is going to reach their out-of-pocket limit because of one unplanned emergency, because that has the unintended effect of preventing them from having any more incentive to change behavior or shop wisely the rest of the year. So that's I think an important piece of it. The other aspect that I would encourage participants to think about is how much of healthcare utilization is, so when we think about this planned versus unplanned question, think about the number of times in your own healthcare journeys that you actually utilized healthcare services without first scheduling an appointment in advance of use. It's actually pretty seldom. It's the minority of the time. And so for every healthcare encounter where you're either scheduling or making an appointment, that's potentially a shoppable care encounter. Because you've demonstrated that you have time to plan. So we think that there's actually a very significant opportunity across probably 80% of the entire medical spend that is truly plannable and shoppable.
Okay. Thank you for that. I will go to Nick, and then Christina, you can probably take the same question. Interesting question from the audience. Is the PMPM model dead? At the recent health conference, there were numerous VC-backed groups talking up the concept of value-based care, true risk sharing model. However, the financial results have been suspect thus far. Nick, to you first.
Yeah, I mean, based off my own professional practice, clients, who I talk to in the industry, I think the PMP model is very much alive in terms of industry standards. I think we're seeing that. Sometimes it's coupled with fee for service. Sometimes it's coupled with maybe other types of add-on benefits. And of course, typically when we're talking about PMPM, we're not talking about the nuts and bolts, meat and potatoes, major medical plan. We're talking about the care navigation, the chronic care management. We're talking about the second opinion type supplemental services and health plan education type services. But certainly in this area of health benefits and ancillary benefits for employees, the PMP model, I think, is very much still alive. Now, will that go away? I think that's going to depend on the industry and where the market goes. And have we had a lot of success with it? I'm not necessarily sure. But I do think right now, based on my experience, there's lots of PMP models out there. There's lots of sort of capitation models. I think because it's also nice for the employer, and Christina can correct me if she disagrees, but there is a nice cost certainty to say, oh, okay, I can use this EAP provider. I can go with this wellness program provider or this telehealth mental health care provider, sort of separate from our health plan. And my employees can go on an app and they can utilize the care. And despite the utilization amounts, they get we as the employer, we pay the PMPM. And so our employees get a nice benefit and we have cost certainty. So I certainly have seen that in the industry very, very popular right now. We'll see where it goes, but at this point, I do think it's still alive in terms of industry standards.
So Nick, I know this panel is on consumer price transparency, but there's a fair amount of consumer curiosity in the Q&As. One of those is referring to that fancy trophy behind you. What is that all about?
That is actually my fantasy football trophy,
Okay.
which I have to give up soon because I lost this year.
Well, thanks for being transparent about that. Christina, to you, I know Nick talked about the PMPM model being alive and well, and I know there was a question in the Q&A before on the TransCaring model. The TransCaring model, as I understand it, is not based on PMPM. They only charge the employers when their employee population actually uses and engages with that service. I know that Accolade is the PMPM model because I've spoken to both CEOs. So how do you look at PMPM?
So I don't think it's going anywhere soon, but not because I want it to stick around. There's nothing more frustrating than looking at engagement numbers and then looking at what you're actually paying. So even though it's price certainty, it's price annoyance more than anything else. So we eventually, with different types of providers, not necessarily our medical and in health insurance providers, but other providers, we're pushing back on that model. And with at least one provider, we've successfully negotiated a different way to look at costs that is beneficial for them to get engagement numbers up, because as engagement numbers up, there's a price increase instead of a decrease, if that makes sense. Mm-hmm. So I think it's due for a disruption. I think if we don't start pushing, then it won't change. And there's nothing more frustrating than the PMPM model when you're looking at it on an engagement basis. So I don't think it's going anywhere soon. I think the people that benefit from it will want it to stay in place, but it'll take some disruption and some employers to kind of stand up and say, this doesn't work for us anymore. Mm-hmm. I think in general, we're going to be moving towards, not back towards an entire cafeteria plan model, but I think there's going to be some disruption in the industry of how we look at choice and benefits and things like that. And that might force it, but for the foreseeable future, I think it's here to stay unless we start kind of pressuring insurance companies to look, and benefit companies in general, to look at things differently.
The known devil, right?
Mm-hmm.
So, Trevor, to you, a physician in the audience has a question for you. He wants to know how you are building a network of transparently priced providers and services. Are you publishing the UHC allowable and copays to the patient for that particular service? Or is the info just an estimate of charges?
Yeah, so the part of the innovation here is in taking all of that historical data about the allowed charges for in-network providers that participate with UHC, and coupling that with their practice patterns, referral patterns, outcomes, so whether that's complications, readmissions for a more complex episode of care. And we look at that think of it as a synthetic bundle of care. So even if the providers are contracted fee for service, we're looking at the entire cost of that episode of care and then saying to the consumer, we should only be varying price to the member based on things that they control, that are within their discretion, and insulating them from the rest. So we form that sort of average, or that expected cost of the entire care encounter, and that could include preoperative and postoperative care, referral patterns, complications, readmissions, right? So when you take that entire picture into account, we then say, let's distill that into a guaranteed price to the member. The provider is still going to get paid whatever they're contracted by the network, but we'll distill it into a simple signal, guaranteed cost that's knowable in advance of use. And that I think is a really important principle, that you can know it, because you can't operate effectively as a consumer unless you actually know your price in advance of use. So being able to do calculations against billed or allowed charges after the fact is not going to make the market work efficiently. You have to be able to distill it to a simple price tag in advance of use. And so when you do that in a way that incorporates quality and efficiency metrics, you can start getting the market to work more efficiently. And in fact, we have providers who are reaching back into the network saying, I want to recontract now for these services because my value-based copay isn't showing up as favorably as I'd like it to. So I'm willing now to recontract for these services and give you a better rate. That's the sort of market efficiency and dynamism that we all want to be happening, and that really would fulfill the promise of consumerism.
Nick, how do you actually define value? I mean, the word gets bandied about so much, and even at JP Morgan conference held earlier this year, we had Morgan Health, which is of course the company that JP Morgan has created to disrupt the employer-based health insurance marketplace. He talked a lot about, value-based health too, but this value seems such a nebulous concept. Is there a way to define it? Is it just, how do you assign a number to value, I guess?
I think that's the tough part. I think you hit the nail on the head, which is, it's very subjective. How do you define value? In terms of my expertise, I'm not aware of any legal definition of what value is. I think, right now we're dealing with sort of objective figures, dollar amounts and fee information and things that are very black and white objective. Like Trevor said, we look at a CPT code. We look at a provider in a certain geographic region. What's the price, right? We have that objective data, and I think that's the problem when we start talking about value-based care and paying for episodes of care. I think it's a noble cause, and I think we're going that direction. I hope we continue to go that direction, but it's hard to measure one's definition of value-based care against another's because we don't know exactly what that is. And in terms of like health plan regulations and laws, there's not much on quality in terms of legal teeth. I mean, we have rules in like certain areas of Medicare where we have provider ratings. We certainly have this idea of ACOs that came about the Affordable Care Act, sort of a team approach to reach a high quality outcome, and payment is provided based on how the outcome is. I would love to see more of that as well, but I think we should definitely see more of that. But besides for those sort of one-off scenarios, I don't think we have laws that really govern, here's how we define value, here's how you must disclose it, which means we're kind of left at the market to decide where that's going to go and which direction that's going to go in.
We haven't talked about drug price transparency much yet. And I'm wondering if you can talk about, any forthcoming regulations that are coming. What do you expect will happen? Because at least Washington, everyone hates everyone, but at least when it comes to drug pricing, they're all aligned, whether they're R or D. So wondering if you can shed some light on that.
Absolutely. Yeah, I think we have lots of changes going on, definitely with respect to prescription drug coverage and PBM regulation, not only the federal level, but also the state level. I think we're up to 45 states that require PBMs to do something. And a lot of it has to do with data disclosures, reimbursements to retail pharmacies and the like. But on a national level, what you're getting at, the CAA does have a requirement that was supposed to take place already. There's been a deferment of the effective date, but at the end of this year, we're supposed to be getting 2 years of data from health plans. And it's supposed to give us information not only on prescription drug coverage, but also aggregate health plan spending. How much was your premium? How much of your health plan spending was on hospital services versus outpatient versus prescription drug? And so I think we're really going to drill down on those buckets of care and how much your health plan is going to spend on those items. But for prescription drugs, there are detailed requirements, and there's a list of things that needs to be reported by the end of this year for both 2020 and 2021. And that's things like, what are the 50 most expensive drugs in your health plan? What are the 50 drugs that had the largest increase in spend over the year? What were your 50 most utilized drugs for the year? And not only that, but we want to know about rebate information from your PBM. So there's lots of attempts, I guess you could say, to remove what some would call the black box, trying to get more transparency on prescription drug coverage, which all of us know is a very significant portion of a medical plan. And as a health plan is paying for all those scripts and making sure those folks, especially with chronic conditions, with ongoing conditions, get the coverage that they need for their prescription drugs. But there is an argument from several scholars out there that say that's one of the drivers for increasing healthcare spending and overall health plan spending. So, the CAA is going to have requirements that are going to come up. We've gotten guidance, we've gotten regulations, we've gotten instructions detailed instructions on how we're actually going to be doing this reporting. And then we're going to get the regulators' summary that will probably go to Congress, and we'll get a lot of raw data, and we'll see where we go from there. But certainly, we are hitting a new wave of healthcare reform when it comes to not only reporting about in-network and out-of-network reimbursement rates, but also prescription drug coverage. What are those expensive drugs? What drugs are increasing in spend recently, and what drugs are being used the most across the country?
Makes sense. Christine, I wanted to ask you about point solutions. We write a lot about startups that help in managing condition A, condition B, condition C, many different conditions, mostly chronic conditions that are expensive for employers. Have you in MasterCard used any of these point solutions to look at maybe your diabetes population or your cardiovascular population? And if not, why not?
So startups are hard to work with because of our security requirements. So we have to be GDPR reliant, even though we're not necessarily always talking about outside the United States. We have very strict data privacy, data security, et cetera. So it's very, very hard to work with a startup. So that's first and foremost. The second piece is that if we worked with every startup that had something that dealt with a specific issue like diabetes, you probably have 200 different people that you'd be working with. So we end up working with them once they're acquired by another company, and they kind of fall into that piece. But as an employer, security and safety of our data and our employees' data is number one. And if they're not going to pass our strict requirements, we can't work with them. Number two is it has to make sense in the whole suite of everything. And if it gets too confusing, then it doesn't necessarily work. So we are a proponent of less vendors, streamlined through one point of contact. Again, employee experience is incredibly important to us. So having too many would just be a problem. So yes, they all have great things, but if you can't get through security of our systems, and if we can't easily explain or fit you into our overall footprint, then it's just not going to work. So it's not something that we do we really don't do it at all, actually.
Okay, makes sense. Thanks for that. Trevor, back to you. How do you know which providers have the best outcomes? Specifically, how do you define the outcomes that are important to measure, and how much data is required to be able to measure in a statistically significant way? That was 3 questions in one from the audience, but.
Yeah, it's a really important question. And I think, as Nick mentioned a little bit ago, this is an area that's entirely unregulated and has been left up to the market to decide. And I'm not saying that's I'm not making that as a normative statement about how things should be. That's just where we are today. So I think certainly there are CMS measures that I believe another questioner also asked about that can be pointed to as probably one of the best publicly available sources of some quality measures that many payers are incorporating in various ways. There are other things that we look at when we evaluate all of the historical commercial book of business data available to United Healthcare in assessing quality and outcomes. And so we even look at things like not just the complication or readmission rates of someone rendering a surgery, but how often do they try conservative treatment first, right? So I think this is a question that's not often been asked and answered well by the industry to date. Quality can't just be I do this procedure well when I cut people open. You actually want them to cut people open less often, because some of the for certain procedures that are overutilized, and when you look at the macroeconomic data of U.S. healthcare, we know that many services are overutilized, and much of the 30 or 40% waste of spend in U.S. healthcare. So price is certainly a piece of it, but misutilization, abuse, misuse of services is another. And so we want to make sure that we're assessing quality in terms of the outcomes when a service is performed, but also is it being performed for the right indications in the right ways, And so how can we design smarter benefits that nudge people to those providers that are going to direct all of the downstream implications of their care decisions in the right ways? So these are big, difficult questions to answer with data, and it does take a lot of data to measure these in ways that are statistically significant, credible, and stable. And that's really important to us, and it's why in our case we are using both CMS measures as well as the entire commercial book of business experience of UHC.
Okay, Nick, we started off this webinar with you, so we're going to start this final round of closing thoughts with you as well. Just in maybe one or two sentences, if you can describe where we are on the path of true consumer empowerment and where we actually need to be.
Yeah, I think in terms of the regulations, we have a lot of legal requirements to get the data, and we're going to probably get a lot of raw data. I think the next step is going to be manipulating, understanding the data, having the industry consume it, and figuring out how we can improve health plans. But I think in terms of regulations and laws, here's all the information we're going to need from you, everyone that's responsible for compliance. Once we finally get that data, we'll see where we go from there. But I think we're kind of at the infancy stage for that part.
And then for Christina, how optimistic are you that this information will lead to true insight about where your costs are than whatever you've had in the past?
I don't think anything's going to change for MasterCard. I'm just going to be very blunt about that, but I'm more hopeful for the industry as a whole. So I think that we are better positioned than others. I think, we're self-insured, so we might get more data than people that are fully insured. So for MasterCard, this is something that we'll comply with. We might get some benefits, but I don't think overall that this is going to be some big benefit. I do think that the industry as a whole needs a disruption. And if we're holding the insurance companies accountable in a different way to help with insurance reform, then I think that's a bigger outcome. But I think insurance reform is the bigger thing here for us, not necessarily anything that's going to impact MasterCard and our employees.
So Trevor, you are one of those who claim to be disrupting this whole insurance mess that we all endure on a day-to-day basis. What are you looking forward to in terms of true consumer empowerment?
Well, I think we're all looking for consumers to get more engaged with the tools that we're all making available to them, the tools, resources, whether human, whether technology. So I think the industry is making great strides there. I'm also looking forward to seeing how payers and providers react to the new world of price transparency. So kind of circling back to where we started with the CAA and the NSA and price disclosures, it does have the potential to change how payers and providers are negotiating and contracting for services. And I think that hopefully will accrue to the benefit of employers offering these benefits and ultimately to consumers.
Great. It's the top of the hour, so we've had this really engaging discussion on a really, really important topic. Thank you to the audience for sending so many questions. I'm sorry I wasn't able to get to all of them, but hopefully we got a good chunk of them to this expert panel. Thank you to Trevor, Nick, and Christina for indulging me with all my questions, and back to the health team. Thank you very much.
Thank you.
Thank you to all of our speakers, Bind, and everyone in attendance today. Please visit our website at hlth.com to catch up on all Health GoLIVE webinars. And join us at the inaugural Vive event, the industry's new health information technology event, coming to Miami Beach, March 6th through 9th, 2022.